Buenos días a todos. Mientras el doctor Peter Lansberg está confirmando su presentación, yo, como podéis ver, no estoy en programa, pero a nosotros nos toca hacer de bomberos y es lo que estoy haciendo yo ahora. Y es un placer para mí presentaros al doctor Peter Lansberg, que ya lo habíamos contactado con él para después la fase segunda de este simposio, por su gran experiencia en la hipercolesterolemia familiar. Él trabaja en Amsterdam. Si tenéis la curiosidad de mirar el número de publicaciones que ha hecho sobre la dislipemia familiar, son impresionantes. Y los nuevos fármacos de inhibición del PCSK9, en este caso el Alirocumab, son prometedores en este campo. Él tiene más de 50 publicaciones en el Alirocumab y es nuestro placer presentaros y que nos hable de su experiencia en Alirocumab en la dislipemia familiar. Dr. Peter Lansberg, it's a pleasure, a big pleasure that you are here. And thank you very much, not all for this presentation, but all the contribution in the symposium.
Gracias. Good afternoon, ladies and gentlemen. As being introduced, my name is Peter Lansberg. I'm from Amsterdam, the Netherlands. I've been working in lipids for almost 30 years. And my main interest has always been familial hypercholesterolemia. And with the advent of the new treatment, that has somewhat gained new momentum. And today I'll try to introduce you to a new modality of treatment, which I think will be very important for cardiology practice. Let me show you a little bit of Holland first. This is Amsterdam. This is our main railway station. And this is our parking problem. It's not so much the cars, but it's the bicycles. We have roughly 750,000 people in Amsterdam and 2 million bicycles. And it's getting more and more difficult to find a place where you can park your bicycle at certain places. Another challenge is that although there's many bicycles, there is also a lot of bicycles stolen. So in order to protect bicycles, some people go to extreme measures. As you can see here, I think the amount of locks represents a higher value than the bicycle itself. But if you really want to hold on to something that is precious, you invest a little bit more to make sure that it will be there the next day. What I'm hoping to achieve today is to convince you that there are new treatment modalities available that allow you to address the needs of very high-risk patients in a better and more appropriate manner. And that is, of course, always a challenge, because when you come up with something new and you have to change your old habits, it takes a little bit of effort and it takes a little bit of trust. Now, the efforts I can't take away from you, but I can show you perhaps a few things that have a little bit more trust in this new type of treatment. PCSK9, that's actually the term we use almost generally, and the reason is the full name is almost unpronounceable. Proprotein convertase subtilisine caxine number 9, and actually there are 8 other ones. And some of them are also involved in lipid metabolism, as PCSK8, which is involved in cholesterol and fatty acid synthesis. Now, the reason I'm here today is because we have discovered that targeting PCSK9 is proving to be a very attractive way to address high cholesterol in certain types of patients. It's a treatment using monoclonal antibodies directed at the protein PCSK9, and it's not an oral treatment, but it's an injection that has to be given every 2 weeks or perhaps even every 4 weeks subcutaneously with a very small amount of roughly 1 milliliter. Now, before I go into the treatment effects, safety and efficacy, let me give you a little bit of the background, because PCSK9 has been around only very, very recently. It was discovered more or less simultaneously in Canada and France as a protein involved in changes in cholesterol levels. And what they discovered, there is a specific gene involved on chromosome 1, 12 exons, and mutations in this gene can give you changes in your plasma cholesterol. And there are two types of mutations. There are ones that we call gain of function mutations, and there is one that is loss of function mutation. Now, PCSK9, as you can see on the left side, has an interaction with the LDL receptor. LDL receptor, of course, pivotal in clearing LDL cholesterol from the bloodstream. And by these mutations, PCSK9 can work more efficiently or less efficiently. And to be honest, when it works more efficiently, it's actually harmful because your cholesterol goes up. And when it works less efficiently, your cholesterol goes down. And we found different families where these different mutations were discovered. And you can see here on the right side a number of these so-called different mutations. Now, the excitement started not when the PCSK9 was discovered in 2003, but roughly 2-3 years later. Because in a population study, the Dallas Heart Study, where they had a lot of clinical data, they did a genetic analysis to discover if patients had mutations in this specific gene. And they found that people that had a so-called loss of function mutation had roughly 28% lower LDL cholesterol on average. Now, what would you think the reduction in cardiovascular risk would have been? What we know from statins is that roughly a 30% reduction in LDL is equivalent with a 20-25% reduction in risk for cardiovascular events. But what they discovered is that the event rate went down almost 90%. And the reason is not because it's a miracle protein, but most likely that this is an effect caused by lifelong exposure to a slightly lower LDL cholesterol. So having a lifelong exposure to 28% less LDL cholesterol translates in a very substantial amount of risk reduction. Now, we've learned more or less the other way around. We learned about the protein, we learned the effects of the protein, while we didn't have any idea yet about the biology of the protein. And there are still a few challenges ahead. Measuring PCSK9 is not easy. There's different forms of PCSK9, active and inactive forms. Also, 40 to 50% of PCSK9 is bound to ApoB, the LDL particle. And measurements have shown wide distributions in the results. So there are still some challenges there. There's different modulators of PCSK9. And we found, for instance, that in males, there's no difference if you're young or old. PCSK9 more or less stays at the same level. But in females, pre-menopause levels are higher and post-menopause levels are slightly lower. And also in pregnancy, there are differences in PCSK9 that it goes up. But in hormone substitution therapy, there's not so much an effect. So there is still some intriguing questions about PCSK9. We've also discovered it's not only targeting the LDL receptors, but there's other lipoprotein receptors that are also regulated by PCSK9, for instance, the VLDL-related protein. And then finally, the biology of PCSK9 is something we're slowly discovering as well. We know it's involved in liver cell regeneration. We know it's involved in insulin resistance. It's involved in some neurological effects. Cancer metastasis has been influenced, but in a sense that higher level seems to be more prone to cancer metastasis. And final, also for viral infections. So biology is still a question, but in lipidology, I can show you already some interesting results. So how do they actually work? Well, then we have to go take a step back and see how LDL is cleared from the plasma. LDL particles are bound to a so-called receptor in the liver, the LDL receptor, and thus LDL particles are cleared and the cholesterol can be used by the liver to synthesize, for instance, bile acids. We also know that the LDL receptor, as seen here, is not used once, but is recycled. So once The LDL particle is bound, LDL receptor and particle are internalized, and subsequently the receptor is released again and can go back to the surface, to the cell membrane. This happens roughly 100 or 150 times. So LDL particle is degraded, but the receptor is reused. And now something interesting happens because we've learned that PCSK9, a protein that sort of disturbs this recycling effect. When PCSK9 is bound to the LDL receptor, subsequently after internalization, the LDL receptor cannot be released and is thus also degraded. And that has severe consequences if that happens in a high frequency manner. What we learned also is that when cholesterol levels are low in the liver cell, that is a signal for the liver cell to get more cholesterol. And it can get cholesterol from, of course, the plasma by incorporating LDL particles. Now, not only is the LDL receptor upregulated, but at the same time, PCSK9 is also upregulated. So intriguingly, if you treat a patient with a statin, of course, your aim is to upregulate LDL receptors, but realize at the same time, you're also upregulating PCSK9. And that's why we theoretically think that statins have sort of a limited effect once you start with your initial doses. When you increase your dosages, the effect on further LDL lowering is sort of limited. What happens now if you block PCSK9, and that's shown here in this image? You block PCSK9 with an antibody and realize this is injected subcutaneously, ends up in the bloodstream, so it doesn't end up intracellular, which is, I think, very nice, very convenient, because you don't influence PCSK9 concentrations intracellular anywhere in the body, but only target PCSK9 circulating in the plasma. And what happens is that then the effect on the recycling of LDL receptors is inhibited. So you get a very nice recycling effect and more LDL receptors at the surface, and thus a lower LDL plasma cholesterol. And how much I will share with you in a minute. Now, at this time, there are two PCSK9 antibodies available in the market. One is called Alirocumab, and the second is called Evolocumab. If you look at the results from the clinical trials, there's not a huge difference between them in terms of LDL lowering efficacy and also in terms of safety. There is one difference which is quite pronounced, and that's that you only have a single dosage for Evolocumab and you have two dosage regimens for Alirocumab. So you can either start low and up titrate or start high and down titrate. Prices for the different dosages are the same. They're administered once every 2 weeks, although in the future there might be a strategy where it's administered once every 4 weeks, although you use a higher dosage than the dosage that you use every 2 weeks. What are now indications for PCSK9 inhibitors? And I think we have to be very careful in the beginning phase of this new drug, because although some of the trials really point out to very beneficial effects, we have to wait for the long-term outcome trials to show us that it's really beneficial and treats the patients not only for lipids, but also reduces events. So primary focus will be on patients that cannot be well treated with the available treatment, so it's statins or a combination of statins with add-ons like ezetimibe or colesevelam. And first and foremost, I think familial hypercholesterolemic patients, heterozygous patients, everybody agrees that they are prime target for this treatment. Then there are patients that have insufficient effects of statins, partly because maybe they also have very high levels, or partly maybe because they are non-responders to statins. A very difficult group to distinguish are the ones who have side effects, tolerability issues with statins. I think that's going to be a real challenge to properly select those from the ones that have more well, not the real side effects, but they experience it because of psychological problems in that sense. And finally, I think a very important group, patients that are optimally treated but still have progression of the disease, maybe come back every year or every 2 years with more events or progression of their symptomatology. Now, how many patients are we talking about at this time? I have some data from Holland. We have 17 million inhabitants. We have 2 million statin users, and our government has just initiated the pricing for PCSK9 antibodies, so it's now possible to prescribe it. And they expect roughly 20,000 patients to be getting this treatment. So it's roughly 1% of the patients that are now being treated with statins. Then, of course, how effective are PCSK9 antibodies? Luckily, we have now a lot of what we call phase 3 clinical data that shows us not only efficacy but safety in larger population groups, although at medium-term treatment levels from 24 up to 72 weeks. And the programs for these two drugs have been focusing on high cardiovascular risk patients, on patients with familial hypercolesterolemia, and also on statin intolerant patients. This is the program from Alirocumab. It's called the Odyssey Program. There are similar programs for evolocumab, and there's a third one that's going to be released quite soon, which is bocusuzumab, and the programs more or less overlap quite nicely. Some of the results, I'm not going to discuss it in depth, but just if you look at the LDL reduction in the Alirocumab group, you can see roughly between 45 and 55% LDL reduction on an intention to treat basis. So that's the combination of patients that were managing to be treated substantially for a longer period and patients who stopped for whatever reason. Roughly, you can see there's a dose-dependent effect. This is looking at placebo. This is looking at different dosages of 50, 100, and 150 milligrams of Alirocumab. And you can see there's a dose-dependent effect up to roughly more than 70% LDL cholesterol lowering. As I said earlier, there are two dosing regimens. There's a 2-week dosing regimen and there's a 4-week dosing regimen. And I just want to highlight what you can expect from these different dosage regimens. Where you see the seesaw effect, these are the 4-week dosing regimens. So you see somewhat a fluctuation of LDL cholesterol over the time period. And with the 2-week dosing effect, you see there's more or less a stabilization of LDL cholesterol over the treatment period. What is nice is that we're now able to shift the curve of average cholesterol from roughly 100 to around 25 to 30 milligrams per deciliter. And that's a new frontier of LDL cholesterol where we don't have a lot of experience. There were a few patients in some of the statin trials that got below 40. We now see that roughly 1/3 of the patients treated with PCSK9 antibodies are roughly around 25 milligrams per deciliter. How beneficial that will be, or how maybe not beneficial that will be, depends, of course, on the outcome trials. Apart from efficacy, safety is very, very important. Again, this is data from a large number of phase 2 and phase 3 trials comparing Alirocumab with ezetimibe as an add-on to a statin, or Alirocumab with placebo, and looking at the most reported side effects. And as you can appreciate, between the two groups, there's not really a distinct difference. Very small differences, and it seems to be that Alirocumab is indeed a very well tolerated compound, and even the fact that you have to inject it, the method of injection is very simple, it's very, very limited painful, and most of the patients that I've spoken to really prefer that to their normal drug dosing regimen. There was one issue that came up in some of the larger endpoint trials or outcome trials, and that was neurocognitive disorders, which is a broad spectrum of neurocognitive related adverse events, self-reported adverse events, and here again you can see placebo versus Alirocumab, ezetimibe versus Alirocumab. the confidence intervals, number of patients with an event per 100 patient years, and again, something that has to be properly investigated, and I think, again, the large endpoint trial will help us to get some more data and some clear objectives about that. Then a very important question, of course, how much does it cost? How much do we have to pay? Well, before I go into the payment part, I just want to show you this slide, which looks at statin discontinuation. This is over a period of 4 years, and you can see that the patients who didn't take the statin for whatever reason, on the left side it's the cumulative mortality, on the right side it's the cumulative cardiac mortality with odds ratios of 3.5 or 4.5. So that is also the price of not being able to tolerate or not being able to use a statin in order to reduce your risk. This is based on Dutch pricing. This is the cost, what we pay for atorvastatin, 80 milligrams, which is of course generic, rosuvastatin, which is still in patent, ezetimibe, and I compare that with PCSK9 antibodies, LDL apheresis, and lometopide, which is a drug only targeted at homozygous FH patients. So you can see there is a huge difference in cost. I've also translated that in a year of 60% LDL cholesterol lowering. How much would that cost? Well, if you use atorvastatin plus ezetimibe, that would cost you 700 euros per year. If you use PCSK9 antibodies, that will cost you roughly 6,000 to 7,000 euros per year. But realize LDL apheresis is 70,000 euros per year, and lometopide, which gives you roughly a 40% LDL reduction, is $700,000 per year. So within the context, I think targeting at very high-risk patients that are definitely not protected with the standard treatment, there is a ratio to do this. Have PCSK9 shown any benefit in terms of morbidity or mortality? Well, of course not, because the outcome trials have not been terminated yet, but we do have some intriguing data that at least points in the right direction. This is a meta-analysis from 17 randomized control phase 2 and phase 3 trials, where patients were able to reduce their LDL from before trial 122 to 51 with an absolute reduction of almost 71 milligrams per deciliter. And if you, in those trials, which were of course not designed to look at hard endpoints, there was a good signal in the sense there was a reduction of all-cause mortality, and also if you look at cardiovascular events, there was a reduction in cardiovascular events. Now this is not hard evidence, but it's comforting to see it points in the right direction. And maybe some of you can remember the CETP inhibitors, where we also had some preliminary data which actually pointed towards the opposite. What about the large outcome trials? Well, this is the program for Alirocumab. 18,000 patients post-ACS, age more than 40 years, with an LDL above 70, below 100, followed for a roughly 4 or 5 years, randomized to treatment or to placebo, and 2017 this trial will be completed and we'll have the results from Alirocumab. There is a few other major outcome trials. Odyssey outcome I just referred to. The Fourier, 27,500. They increased the number of patients, and it will be presented in 2016 at the American Heart. And for bocusuzumab, the Spire 1 and 2, 18,300 patients. Intermediate results were also very promising, so that can be expected in 2017 as well. So, to conclude my talk, I think we have a very exciting new compound targeting the very high-risk patients which you as cardiologists are most likely to see. These are the ones with very high levels of cholesterol. These are the ones that are not able to tolerate the standard treatments or who have progression of the disease. And what we've known so far, I think it is safe to say that at least in terms of lipid improvement, there's definite benefit, and it looks like there's going to be also some outcome improvement, and hopefully in 6 months' time, we have some more data on that. My last slide, a few years ago, I was driving through the UK, and when I was driving, there was a big sign saying, the Brompton car repair is the best car repair in the area. And the reason is we are fast, we are cheap, and we are reliable. However, you can only choose two. That means if you want to have it done fast and reliable, it's not going to be cheap. If you don't have the money, of course we can do it, reliable, but it's going to take a long time. Yeah? So I like this sort of image also for this new treatment. We cannot afford to be non-reliable, so reliability is first and foremost. But in some patients, we cannot afford to be slow. We have to be fast. And I think these are the first group of patients really targeted here, very high-risk patients in need of better management of the lipid levels. And then there are, of course, patients where the risk is maybe not as high, where we can have a little bit more time to manage their risk factors, even in a primary prevention setting, so we can be reliable and we can be actually a little bit cheaper because we don't need to be so fast. Okay, that was my last slide, and of course, I'm here for questions. Thank you very much for your attention.
Thank you very much, Dr. Lansberg. Some questions from the audience? Okay, if there are no questions, I have a question.
Yes, please.
Okay, one of the big problems of all the PCSK9 is the safe long-term
safety. Yeah.
Because it's not clear now. And it's possible to think about that the cholesterol is in the body is for some reasons to decrease and decrease and decrease the cholesterol. What can happen?
Yes. So the main point of the question is, with PCSK9 antibodies, cholesterol can go down really low. You know, we see that a third ends up with LDLs around 25 milligrams per deciliter. And your question is that safe? Is it not that as a body we need maybe more LDL cholesterol? Well, there's a lot of data out there looking at what I call a normal or a physiological cholesterol. And what we do in medicine most of the time is we look at the population, we make a bell-shaped curve and say, this is the 50th percentile and 2 standard deviations, that's what we call normal. I think for cholesterol that is not the case. There is a lot of data on biology, on cell biology, that points out that an LDL cholesterol, when you're born, no, not LDL, a total cholesterol when you're born is roughly 50 to 75 milligrams. Now, what happens after you're born? You start drinking milk. And what happens then is your cholesterol goes up because it is high in fat. And we share that with all other mammals. If you look at goats or sheep or pigs, the same thing happens. Birth, total cholesterol 50 to 75. After weaning, cholesterol goes up, but when your weaning stops, cholesterol goes down again. But what happens with humans, after we stop breastfeeding, we start drinking bottled milk. And after bottled milk, we start getting a westernized lifestyle, and we keep our high cholesterol, and our cholesterol actually goes up. Now, there have been studies done in some primitive populations, in Malaysia, in South America, in Brazil, where they looked at a traditional hunter-gatherer lifestyle. And what you find there is that cholesterol levels is actually at the same level, roughly around 50 to 75 milligrams per deciliter. Do you see cardiovascular disease? No. Do you see strokes? No. There is almost an absence of atherosclerosis in those type of patients. So I feel very confident that an LDL cholesterol between 25 and 50 is really not an issue. What we don't know is what happens when LDL goes below 25, because we don't have any experience. Yeah, we have some individuals who are homozygous for some of these rare mutations, and they have LDL cholesterols of 10 or 15 milligrams per deciliter, so very, very low. Do they have any problems? None whatsoever. They seem to be very healthy. They seem to be not exposed to some of these factors that I told you earlier, like diabetes or liver disease. But on the other hand, the number is of course so small that it's very difficult to draw your conclusions based on these facts. So what I would suggest is if we are able to get below 50/25, I would be very, very happy in these high-risk patients. But in most trials, when it gets below 25, there is going to be an up-titration, either by changing the dose of the PCSK9 antibody or by changing the dose of some of the add-on treatments like statins and ezetimibe. And I think at this point in time, that's a safe approach. We can learn in the next few years what the outcome be in some of these patients that will actually get very low levels, because I'm sure that that will happen, but not as a general sort of directive. The lower we can get, the better. I think between 25 and 50 is my personal, not evidence, but personal opinion of a safe level.
Thank you very much. Is there no more questions? Pues pasamos ahora, lunchtime.
Okay.
Pasamos ahora, hay una hora para el almuerzo y nos volvemos a encontrar aquí a las 3 de la tarde. Muchas gracias a todos por la asistencia. Thank you, Dr. Lansberg.